All right. Hey, everyone. It's me, Dr. E, Dr. Ellen Fitzenreiter, we're talking about addendums today with Rebecca Walter, who is I'm going to let her talk a little bit more about herself, but today we're specifically focusing on addendums and why to do them and when to do them and how to do them. So, Becky, if you could chat a little bit about your experience helping docs and your experience doing all this.
Oh, sure. Thanks for
Yeah,
having me, Dr. E. My name is Becky Walter. I am Rebecca also. I have a medical compliance specialist certification, which is a national certification regarding not only documentation, but other federal regulations. Plus, I have about 30 plus years of experience running a Virginia office. Many of you would know my husband, Greg Walter, who's past president of the VCA and ACA delegate and blah, blah, blah. So who has now semi-retired, but I'm still working. I did also work some for KMC University for several years, speaking at different events and performing audits. I have performed hundreds of medical records audits. Most recently, I was working for a short-term time with Carilion Clinic, helping them get documentation going in Epic for their therapies and cath lab and the radiology department. So lots of tech experience, loads of medical records experience and auditing experience. So that's what I come here to share today.
Great, great. And so you know a lot about chiropractic, and then you've also done other things, other healthcare providers. So, okay, great. Well, let's see. So addendums are, so when a signed note is opened, information is added and the note is re-signed. So it changes, I guess this should have been the second slide, but yes, this changes the date. So when to do an addendum: when a required element of documentation is missing from your notes. And so, Becky, if you can give an idea of maybe what some oversights might be that a doc might find out about.
Yeah, generally, you don't review every note every time after you go through it and create it on that day. That would be too laborious. And so either you hopefully have a planned time to review some sample notes, or if you don't, it's when you get that request, right? You get the request and you start looking and you realize a couple of things, and you can do an addendum, a simple addendum, when facts are obviously erroneous inside the documentation. And some good examples are, let's say you've got orientation wrong, like it's obviously everything, all the symptoms are on the right side, but somehow in your testing procedures, you recorded a left straight, right, leg raiser, excuse me. For example, that would be something you could obviously say, this is a human error, and it's obviously right when I said left. You may even be able to do that with a lack of diagnosis. If you have full support for a specific diagnosis in your exam and in your complaints, you have an OPPQRST, and you have everything documented for your for a specific diagnosis, but you omitted it by accident from your diagnosis set, that may also be something. Facts are obviously in evidence. What you can't do is create facts that are not someplace in evidence. And so that's why addendums can be helpful, but they are also often seen as a suspect from a reviewer to wonder, did you create documentation when you received the request and it was not there before? So that's what you have to always keep in mind if you are choosing to add an addendum to your medical records. That makes sense.
So that was interesting, because as somebody who has survived an audit, and I'm still fighting certain elements of it, is diagnosis, and that's a common thing to get denied, at least with the docs who were in prepayment review last year in Anthem here in Virginia, is they said the diagnosis didn't support what you were doing. So if your exam findings and intake, you mentioned earlier today when we practiced about the intake, if that supports adding a diagnosis, you can do that. How can you explain that a little bit more?
Well, so let's say, and I can think of an example. Let's say on intake you have a history and it shows a history of osteoarthritis or treatment for such, or some other underlying disease that was in the medical record that would create a degenerative situation, obviously. And let's say that in your exam, and what I find a lot is that a lot of docs, unfortunately, you're doing this great exam, but you're not writing down enough of the elements, right? And so if you just have enough written down in there, but you failed to document some kind of degenerative process, and all you're documenting is, let's say, spasm or pain, which are very, very short-term care situations, and that's often why they deny due to documentation. If that's the case, but you had the supporting, both in some kind of written document the patient supplied, perhaps it's copies of notes from another provider, or it is, just their history, you may be able to support. Well, maybe it's an old X-ray report that has degenerative changes. You could support a degenerative diagnosis. The problem with that is, and here's the caveat, if you have multiple days past when you should have realized by looking at your records that, oh, I didn't address this degenerative disease, this may not be taken very well, because if you've got 16 visits on pain, they would expect you to at least have seen it somewhere along the line, and to say at that point, make an addendum, oh my goodness, I didn't do this, and then carry it forward properly for the rest of the time. So there is a bit of it's a challenge there if you go back and find it, but certain small ones you can do.
Okay, all right. So, and then how would a doc, I guess something that comes to my mind is going to a workshop. You go to a great training about documentation because you're trying to do due diligence to make sure you're doing this correctly. And in the workshop, you realize, oh my gosh, I am not doing this thing that I know I need to be doing. So that's one way to know that something is missing. And then another one is if you do have a professional look at your notes, if you want to have that more focused look specifically on your own files by somebody. So a workshop or seminar, actually getting your guidelines. And I talk to docs all the time, and 99% of the time they don't know what their guidelines are for their carriers, and that's a problem because you can't say what they want you to say without you knowing what that is. And even at our recent convention, a doc raised her hand and she goes, well, if they just would tell us what they want, and they do, that's what this is. And you have to know to ask for them if you haven't read them, and then once you know your guidelines, then you know what has to be in your notes, and then reaching out to a pro.
Yeah, you do need to. I talk all the time about self-auditing and knowing what you're auditing for. And you're exactly right. There are medical review policies. All the carriers have them. They may not make them easy for you to find, quite frankly. For ERISA plans, maybe they have a summary plan description. So you have to medical review policy for general carriers, summary plan descriptions for those who are self-insured. You have, for Medicare, it's an LCD, local coverage determination. So you kind of have to know the lingo or reach out to someone who does. And once you do, create a file of those so that you can then look at your documentation and do it at the most common denominator, the highest level. You generally, if you document to your highest level across the board, you don't ever have to be concerned. If Blue Cross has a more restrictive signature policy, which they do, then you should set all your signatures to be the same so you don't have to worry about it. No one cares if you do more, usually.
Mm-hmm.
They do care if you do less.
Sure.
And getting someone to look at it who knows. Just because you may still be in doubt, and it's right to get someone who's trained as I am, has a certification, to look at it for you.
Sure. And in your experience, when a doc calls you, it's usually because they're being audited? How many docs just sort of proactively reach out?
Once in a great while, someone gets frightened because other doctors that they know have been audited, and they will be proactive and reach out. And that's the best of all, because we can draw a line in the sand. We can't go back and fix that old stuff, really. I mean, unless you have the paper documentation that helps you support an addendum with more facts, which sometimes you do. But if you have some kind of therapy records or things, those paper documentations can be referenced in your addendum. But if you don't have that, then you can't go backward, but you can draw a line, and that really does help. If you get audited on a past one and you have drawn the line in between and improved your documentation, usually they will look at the documentation that you do now, and decide whether you still need to be in some kind of improvement or under review or prepayment situation or whatever. If you've already improved it, it saves you some headaches.
Sure. And I would add that some audits are more aggressive or assertive than others. And I can speak for the docs who were audited by Anthem last year, like I was, and they were taking no prisoners. I'll put it that way.
Anthem is not, they don't have a prisoner cell.
There you go. It
Yeah.
was awful. And I will also add, so if you're a doc listening to this, whether or not you should have a professional look at your notes before you get audited, or, well, I'll wait, if I get a letter, I'll worry about it then. I will tell you that if you're in audit, especially once you get in prepayment review, you do not want to be fixing your notes while you're not getting paid and you're going through your reports. To be proactive and take care of this before it's a problem is crucial, because otherwise you will be at your office at midnight.
Or later.
Yeah, or later, or go under. And both Becky and I know docs who lost everything because they got trapped in trying to get this all done and not knowing how to do it. You need to be proactive. And you also might realize that maybe for your style of practice, the guidelines and what the carriers that you're participating with is just more than you want to do. And if you've been thinking about going cash, and you can make an informed decision that you're just not going to do it, or you're going to do it. And I like to say it's cash or cake. You're going to go cash and you document for cash. And Becky, what do you do when you document for cash? What do you have to hold up? What are the standards?
Well, you have to exclude Medicare patients, and unless you're going to stay in Medicare as a non-par. And to document for cash, all you need to do is make sure that you meet the state guidelines and your malpractice guidelines. So you're going to make sure that you're covered. You've done everything treatment-wise that you need to do to document, so that it goes what the state board makes you do.
Sure. So going cash does not mean you don't have to take notes or substantial notes. It doesn't let you totally off the hook. But if you're going to participate with carriers, and you're going to, if you want cake, you need to earn cake. You can't document for cash and do that. So you
Being
mentioned
proactive is real important, and I think that is a key thing. If you do that, then you will be able to have plenty of time to clean up your messes before they get, and it'll shorten your prepayment review by a lot.
Yes.
Once they know you're doing it right. So
now I clicked forward, but then wanted to, you mentioned about paper documentation.
Sorry. I turned it off. There we go. Okay, sorry.
I have to close my shutters so the dog doesn't bark at the dogs going by when I do these two.
We have this cool thing at our house that when you're someplace else and your cell phone rings, we have this little system, and that's what you're hearing. So,
yes.
I'm trying to turn it off. It doesn't want to turn off. There it goes.
Got it. Okay. So what is an example of paper documentation that you might have in your office that would be a legitimate thing to make an addendum for?
Well, as we already had spoken about, intake forms that would have history, medical history, family history, could be referred to, or you could have left it out in your exam and referred to it, or maybe you skipped it and you go back and review and it's there. That's one example. Another example is many offices that I work with find that they have assistants that are helping with some types of therapy, and maybe they're using a paper form to document placement, time, area, settings, all of those things, and they've got those initial for staff. Again, it would be a perfect thing for you to be able to use you're not really creating new documentation, but you're taking that paper and placing it into your EHR system. Or you can reference it, you could copy the whole thing. What you don't want to do is make something more extensive than that is, or make something up, or try to use your brain, because contemporaneous is the word. Documentation must be contemporaneous to be valid. And that's why they get you on these dates, because if it's more than, when some states like Alaska, they allow 72 hours for you to complete, but the general rule of Virginia is 24 to 48 hours.
Yes.
And so If it's older than that, and your system, your EHR system, all of them hold keystrokes and dates and when things were changed. And if ever you need to prove that you didn't, well, you certainly can. But if you're trying to hide that you did, you certainly will not be able to.
All right. So the bottom line is if it's not in your notes and you find out it needs to be in your notes and those notes are closed and you don't have any other documentation anywhere in the office that says that you did what you did, even if you didn't, you cannot open up that note and change your note.
Right. You should not.
Right. You should.
Should not. You absolutely should not. It is fraudulent. It could be enforceable by law. You could have a board complaint. That's the worst thing in the world, have to go before the board. Medicine in Virginia, no one wants to do that. That'll kill your practice all by itself, just the worry from that kind of thing.
Sure.
So you want to avoid that. There are some things you can do though, and I'd like to, and I didn't speak about those too well this morning, and it just hit me between you and I earlier, that make some of this process better for the reviewer. And you may be sitting there, why in the world would I want to do that? Well, the reviewer might have 20 files on their desk, and their job is to get through them, right? And they usually are nurses, most of them are RNs, and they have a quota that they have to get through. Some things that you can do is to make sure that your package of information with all of your copies of anything that's paper and anything that you've printed off or created a PDF or whatever things you could do is organized. And I can talk to that at the end. And that will help you know you sent everything and help the reviewer or be organized a little bit more in their review. So remind me to talk about that towards the end.
Okay, so reviewer. Now, I would say that in my particular audit, there was a high degree of Anthem reviewer errors. And one particular thing that popped out is when I would put some functional testing percentages and scores and changes as a flow over through the ADLs in the subjective portion versus the plan. I mean, they were in my notes and they would tend to miss it.
Yes.
Not all the time. And then I did shift it over to the goal portion, on the plan portion, and they see it, but anyway.
Well, you see, that is a great example too of what you could use an addendum to say. And on review of your note, you would have had to have known this before you submitted it. On review of your note, you see that your ADL deficit and improvement was erroneously in a subjective, because that means this is what the patient is stating, not what you, the doctor, are really recording as your observation. They want your professional opinion on the ADL, not what the patient's. They want both, not only what the patient says. So
yeah, and the macro and the I was using ChiroTouch at the time. The macro flow kind of led into that, and I went up and tweaked it myself. So anyway,
and you can. But
all right, so. Yeah. All right. So now back on our page is what documentation should I worry about? So if you're not being audited and you realize there's something you haven't been doing that should be there, how much should you worry about old stuff?
You really should draw a line in the sand and only work on the things that are current and contemporaneous. You should make a note in your compliance documents in your whole program that you found this, and here's the procedure you're going to use in order to correct this going forward, and what you'll do if you're asked for these records in the past. And it may be something that we spoke to that could, an addendum. It's in the wrong section in my notes. It's there, but it's recorded in subjective, and it should be assessment or plan. Would be a proper thing to have as a plan in your compliance plan. Say, I found this. Forward, I'm changing my macro, or I'm doing something differently. In the past, if I get audited, I will create an addendum at that time to explain why it's there. But it's not necessary to go back and addendum every single file at that point that you believe is wrong,
because you can never do that. You have to practice.
But you should have it recorded in your compliance log. Hey, I discovered this. I audited, a self-audited or got audited or something, and I found this out. Or I went to a seminar. Here's what I'm doing now that's different. I'll do this. And then when you get that request, you go look at your log and say, did I address this? Oh, yes, I did. I even advise people to copy that log and throw it in, even though the reviewer won't know what the heck they're looking at.
Hmm.
When you do that, it will be there in the documents in case you have to appeal their decision.
Okay. Now everything changes once you've gotten an audit letter,
Mhm.
because normally they will go back, and in the case of last year, is for most docs they went back a full year. And I know my documentation had changed a lot in over that period of time, because I was always working on things.
Mhm.
And then you are in a position where you have old stuff that they are asking you to send them. Mine was 10 files for 6 months, and I know some docs who had to do 28 files, and then most people were somewhere in between. And if you can chat a little bit about that, when docs are reviewing their notes before they send them off.
You mean once you have an audit letter and you're
Yeah.
reviewing your notes, and you need to really have that policy, the payment review, the coverage review, that document that says what it is they want. If you haven't pulled it up beforehand, now's the time to make sure you have that so you understand what they might be looking for, and search everywhere in your office to see if there's any paper documentation that will support some of those things that might be missing in your documents. And that's just important and time consuming. And I know that you get a 15 chart audit, that's a lot of work. That is a ton of work. But is it better to spend 2 nights staying there till 10 o'clock than to lose your practice? Yes, it
Sure.
is.
Sure.
And so when you do that, then that's the time to really start thinking about organizing the chart, making sure identifiers are on everything. You page number the thing, one of, two of, three of. So again, 20 files on the reviewer's desk. What if the wind blows?
Yeah.
And you want to
Yeah.
make sure that that's good, because that has happened many times. They sent it and it lost. It's somewhere in the way. So,
Yeah.
but doing all of that is really, uh, you do that, but and then when you find, wait a minute, I've searched everything and I just don't have this, that's when you need to reach out to someone and get a review and see if they support what you think. And so another opinion, someone who's qualified, and then draw your line in the sand from that point and go forward and start putting some money away, because if you feel like they're going to have they're going to ask you for money back, you better put it away. If you decide actually on review that this is definitely wrong, you have the right to include a check with your submission too, to say, I know I've missed this one visit. This is wrong.
Yes.
I'm going to pay that back to you. That
Wow.
actually goes a long way to helping them understand that you're trying to do the right thing.
Okay. I hadn't heard of that
Yeah.
before.
Mhm.
So normally they'll go back for a period of time, and they'll say that you did not substantiate consistently a particular therapy to their degree, which means they're potentially going to ask for that money back. It can be a lot if you do a lot of therapies. And then at that point, they'll also say, since your documentation doesn't show you're doing what we want you to be doing, we want to put you on prepayment review to clarify that the correctness of your claims. And that can be paralyzing to your office, because now you're not getting paid until your claims are the documentation is meeting their standards. And if you're trying to fix it then while you're practicing and while you're not getting paid, it's really hard to do.
It's very difficult. So yeah, I would recommend that you take these audit requests seriously and make that be a prompter to review your documentation across the board and say, am I meeting standards? I'm just going to do this all the way across for different carriers, or however you set your standard. If you haven't set a standard, it's a good reminder to set your standard and make sure that you have a good macro in place, that you've been reviewed, that you can go home and sleep at night would be really nice.
Sure. Now, we also talked about, so once you're in prepayment review, there is a denials detail report. So make sure you know that, and make sure as soon as those claim forms process. And so one of the issues last year was that the denial was very vague. It wasn't specific reasons. It basically just said that documentation was required to be reviewed. Well, all of us docs, we had submitted the documentation, so everyone was under the impression that it hadn't been read yet. And this went on for months and months, and it turns out there were specific denial reasons. It's not on the EOBs. You had to ask your auditor, but nobody knew that there was one to ask them about it. And my auditor said that he didn't even have anything to do with prepayment review. Unfortunately, I have all this in email communication. So
the audit report, and it can be called many different things by different carriers, but that's just a generic term. It's an audit report. It's going to be a bit more specific reason. Let's say, for example, it's a therapy denial, and maybe it's 97110, and you didn't have enough detail in your documentation to support 15 minutes. Maybe you shorted it that day, your finger slipped, whatever happened, you didn't have any detail at all, or there wasn't anything to say that you really did that service. And that's the one thing they're denying, and you can't understand it until you see the audit report. And you've seen yours, Ellen, and you know it does have many more details. It can be pages and long, and without that, it's very difficult to appeal. I'm the appeal queen. Everybody in the country says I am.
okay.
So,
You heard it here.
Even Kathy Chang says I'm the appeal queen. So the thing is that if you've got that document, you have something to know what to appeal. You can go in and say, well, that's not true because it's right here. But maybe that page flew off the desk, or maybe something happened. You can go back and say it's on page 16, line 27, whatever it is.
Sure.
And then you'll win.
Yeah.
It's there. And
yes.
That's very important to do. Very good.
Yeah. All righty. So, so we already talked about this, what you can do in addendum 4, what you can't.
Yeah.
What happens to the EHR record when you make an addendum, because it does change the date that it says your note is signed. And yet we talked about earlier that your note should be signed within 24 to 48 hours. So it changes the date. What happens then?
Well, it changes the date on the signature date that you would see that prints out. Like, let's use ChiroTouch because that's what a lot of people use. In ChiroTouch, internally, it date stamps the document on the internal audit log in your EHR, and every EHR has an internal audit log. Some are more basic than others, but they all have them, and that usually consists of who signed in and what patient you were working on and what you did. Basically, every keystroke is recorded in some fashion on this log. It's not that hard to access it. If you look around, you can certainly find a link to your internal audit log. When you change that, you should really, so that it prints out well, make sure that you have, and you had a great example earlier. Let's say this addendum, that was on there. That's going to come up. That was, it was originally signed on September 15th, but on December 17th, I discovered that there was something wrong that said right instead of left. So you say original note signed whatever date, and here's the new stuff, and here's why, and then it'll sign again, and it'll have the date that's today. That's what really happens. Now, you also had a good example about taking a screenshot, making a PDF. You could argue that you did things before you ever took that PDF.
Sure.
But people can argue anything. They can argue with anything except that audit log. It cannot be changed. Sure. It is impossible to erase it. It'll show everything you do. So that's good to know.
And the audit log is not something that you would normally send in with them, but if this ever went to really escalated to a higher level of appeal, you would have that. And what I did in my circumstance when I was, and my primary issue that happened along with my audit was my therapists were doing notes in ChiroTouch as a provider, documenting everything they did, start and stop time. They signed it. It was date stamped, and Anthem wanted their license number and expiration date. So everything else was correct. Mm-hmm. Now, in my case, my denials report said it wasn't signed. Well, it was signed. That was why, they didn't give me the right denial reason. It isn't signed. When it was signed is different from not having the credentials there, and that's why I'm getting some money back.
Yeah. So for them, for Anthem, they consider if it doesn't meet their signature guidelines that it's not signed.
Yeah. Yeah. So, so what I did is when I did my addendum, which I'm going to show in a minute, is I went to a print the note and I saved it as a PDF. I put it in a folder in the patient's file, and then I did the addendum. So I had the original note with the original date signed and the addendum note to show that I had only changed that and nothing else.
Yeah, that works
So,
well for a lot. I mean,
okay.
that would work well for someone who has paper documentation. Take a photo of your paper documentation, and this was the date, and then just so they prove you do not ever, ever, ever want to go back into the body of a note, whether it's printed, handwritten, or EHR, and make a change. That is a big no-no. You never make the change in the body of the note. You leave it alone
All
and
right.
then
So
explain afterward.
which is so an addendum isn't, you don't go back and fix it where it appears in your note. Your notes stay um, untouched, and the
Right.
addendum is added at the very bottom with whatever it is you need to see. And so this
Just
is an
like what you have
example.
on the screen.
There we
Yes.
go. So this is when I added the license number here. The amendment is to add therapist credentials to an existing handwritten note for documentation request. The starts, everything else was on the other note. And then eventually we had EHR, but for about 3 weeks we had handwritten notes when it was signed on 6/4. And then if you see my signature is dated when the service was done was 6/5/2018,
Right.
and the therapist addendum was added on May 15, 2019. So that's how we did that. All right, so outside professionals, what do you need? And while I was in the middle of an audit and waiting for things to process and nothing was happening other than me not getting paid, you're kind of desperate at this point.
Mhm.
It's awful. We had therapists we let go because I couldn't pay them. We couldn't provide covered services to my Anthem patients because you can't provide what you can't pay for. And I was exploring different options with different services, and they said there's a 3-file review, there's annual service plan, open consultation fee, and I didn't know what I needed. So I paid for a 3-file review. It was like $999. I didn't need it because I didn't need Medicare file reviewed. I didn't need my non-participating insurance review, which is the other two of the file review. I needed something very specific, one file. Here's my Anthem people. You look at it and give me some information back that I can work with. So they ended up prorating it after the fact. When we realized we had only used a couple of hours of time, they charged me an hourly rate and I got a refund for the balance. But they really didn't have a service that was what I needed for that, and which was what it was so hard. And so go ahead and you can.
Yeah, so knowing what you need is pretty hard for us because I'm on the consult side and I did work for KMC University and I did those 3-file reviews, plus I did hourly reviews for people in the situations who were having an audit of a date of service, that they needed to understand what to do and how to respond to the audit. I did all of that for KMC, and I know exactly what you're saying. Docs don't you This is not your field and you don't know what to ask for. 3-file
Sure.
review is a great thing to do when you are trying to be proactive. Can you
Mm-hmm.
just follow that up with what I just said earlier? You need to know, am I meeting these guidelines? And you may submit 3 different carrier types which is what I would recommend, and have someone like me look at it and say, yes, you're meeting this one, but you're not meeting this one, or whatever. And that would be what I would do. If you feel like you need a ton of training, and a lot of what we said today is Greek for you, you probably need someone to consult with that is an annual service for you, or someone that at your beck and call, like I used to be the beck and call girl, right? Because my name is Becky. It's very
Becky,
funny.
there you go.
Or you just may need an hour because you think you're okay, but you want somebody to tell you if you're okay and help you answer this request in the best way. When you do call into any of these services, and I keep saying KMC because I was part of them, and the people there are very well trained, just as I am. I mean, but to know what you're asking for is real important. Say, I have an audit. I need to know how to
That's
respond to this audit. I
yeah.
may want a 3-chart review in the future so that I know how to best proceed going forward. Right now, my pants are on fire.
Yes. that was clear, and it took weeks for them to really respond, and I was
Because I
worried
left
about
them.
paying
I'm
the
so
mortgage.
sorry.
It was awful. You don't want to
If
be
I had
there.
been there, it wouldn't have taken weeks, but
There we go. You were gone.
I
Yeah.
left. So sorry, it's all my fault.
Okay. All right. Let's see. So I actually got a grade. Who it just you need, I guess, so somebody, a professional like you say, okay, this needs to be in your notes. Is there any sort of further, this is how I would recommend to do that, or beyond just saying here are the missing pieces?
Well, generally it would be, I mean, I couldn't give you a step by step, but I would say it should say blah, 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 and it doesn't. That would be why. Now, for me to be vague and just say, you don't meet medical necessity, that would not be helpful to anyone at all.
Hmm.
Because then well, what do you mean by I don't meet medical necessity? That's something Anthem or Medicare might send you on an initial review, right? You don't
Hmm.
need to pay for that. You need someone to say, you didn't document to this to support your diagnosis. You don't have any findings on your exam at all other than range of motion. So you don't have anything. So in the future, you need to flesh this out a little bit or whatever it is. I'm just using that as an example.
Sure.
You didn't, you put your functional deficits at the beginning and at the re-exam, but nothing in between.
Hmm.
That's not too hard to follow. And a B plus on a 3-chart review means you've got work to do. You're
Hmm.
not bad. You're not completely failing, but there are missing elements. And if they didn't tell you what those missing elements were, I'm sorry.
Sure.
They should have. They should have said, this is wrong. This failed. This failed. If it was too vague, I'm sorry. It should be that. And then if you need more help, you can't understand that, you might need one-on-one kind of coaching or something to help you learn, because there are some docs out there who really didn't learn this in school.
Sure.
You know how to do it. So
Absolutely.
yeah,
Yeah,
that's
and so yeah, and in my case, they had reviewed my prepayment review notes, and I had already made a lot of changes also. So it's an ongoing process of
yeah,
changing those
yeah,
things. So
yeah. It's and you should it should be an ongoing process,
yeah,
because you think they leave those medical plan summaries and all of that stuff the same all the time? They do not. They
yeah.
change them yearly.
I would also say that if you are with one of the larger software companies, you need to go back to your EHR software company. You need to make sure you have current macros. You need to know how to use them. You need to watch the training videos,
Mhm.
because the big companies, they are building the macros to help you be compliant, and they can't do that if you're not using those macros, and if you're not watching the training videos, and you're just trying to, you're just not going to type all this stuff in by hand every time. It's impossible. Your macros are a tool. You're paying for your software, you're paying for ongoing support along the way, but most docs aren't using it. So
Yeah.
say that. All right, so we covered when to need to file review and what, and carrier dependent. So right now is if you want to talk to Becky about files that you've got, here's her contact information, and uh, I guess you have, this actually is on my blog, which anybody anywhere can be seeing, but you are the insurance specialist for the Unified Virginia Chiropractic Association, and you have a special pricing for UVCA members. And if you want to chat a little bit about, for a single file review, if you could chat a little bit
And a
about that.
single file review is really appropriate when you get an audit,
Hmm.
and not necessarily 3-chart. And I think we've said that. And for anyone not in the UVCA who may be listening to this, I charge $150 for a chart. And for UVCA members, I reduce that to $100.
Hmm.
And that it will include a review and talking about the coding as well. We're just talking documentation here, but
Yes,
CPT coding also drives your documentation. Did you document to the code? Were you able to really support that billing? Did you bill appropriately? Let's see what's going on here. Did you use correct modifiers? That's what that $100 is for, to see if for
sure.
that patient, that chart, you met the standard for what you're doing.
Sure. And if you spend $100 to find out that when you get an audit letter, you've got what you're supposed to have, talk about not a lot of money for peace of mind.
Yeah,
You don't,
it's an inexpensive insurance policy as long as you
absolutely.
keep doing it. Then
Yes.
if you keep checking on yourself, because things fall off the track. it happens. You get busy and you might accidentally inadvertently change what you're doing and then copy that forward and there's so many ways you can fall off the tracks. It's just a good idea to do that. And then you may want to have the free chart review, which I don't even have a price set up, but that's a much
Sure.
more extensive review, and that would be more expensive, but it wouldn't be $900, but it would be more expensive than that. I don't
Sure.
have overhead like KMC University,
Yeah.
so.
Yeah. Now you said to remind you something about helping the reviewer out at the end.
Well, I kind of touched on it a little bit, but
Okay.
if you can make sure that when you gather all your documents together, that the patient's name and some other kind of identifier like date of birth and your facility name or your doctor name, however you're set up in the system that's auditing you, is on every single page that you submit. So patient identifier and provider identifier. And then somewhere also on the page 1 of, 2 of, 3 of. I know that seems like a lot of little petty little things, but it will make a huge difference, because you imagine you honestly do have reviewers are just getting handed these things. They may have 20, 30, 40 on their desk, honestly, and they're going through it as fast as they can. Plus, if you are going to submit it all in a mailed form, a lot of people want to highlight things. Highlighters, when they're copied or they're scanned in, and most of these are going to get scanned in sometimes, then that highlighter covers things up and you can't see it. So avoid highlighting. If you're going to draw attention to something, a big circle around it
Mm-hmm.
is better than
Sure.
highlighting.
Sure.
So, and then make sure that signatures are the thing that most often are a problem. Really, it's an easy problem. That's one of the first things the reviewer looks at. That is an easy denial. Signature is illegible, doesn't meet standards, or is missing completely. Then they don't have to do any more work. They close the file, stick it over here, and said denied.
Sure. I would add to that if a provider is not signing their notes or not signing them properly, they are probably doing another 10 or 20 or 30 things wrong. Because if you don't know that simple thing, you probably don't know all the other elements that are also supposed to be in your notes. And the reason I say that is docs will say, oh, well, they'll watch a seminar or a workshop and they'll say, oh, well, I signed my notes, I'm good. And the reason why review auditors say that's the number one reason for denial is because they stop there. But it doesn't mean there's nothing else wrong. So just because you sign your notes does not mean nothing else is wrong. So you need to have somebody look at them if you are not certain that they're compliant. And another thing I like to say is you're not compliant by accident. You don't guess and happen to say the right thing. You have to know what they're looking for, and you have to say that in order for you to be compliant.
You've learned a lot, haven't you?
Okay. Yes. And and a lot of it is just communicating with people and sharing stories, because docs don't like to talk about being audited. And in fact, I used to post in the listserv and they'd say, well, if you did this right, you wouldn't have. I was like, you have no idea what it is like going through this. And people would reach out to me privately, but they were embarrassed. And it's like, we need to stop taking that embarrassment out, because what happens is docs keep information to themselves and we can't share that, and reach out to our association or our specialists or our larger associations and do something. When carriers do something wrong and they're getting away with it, they're getting away with it because no one is doing anything about it. So that's what I'm trying to do.
Thank you for doing that, because it's important. Most people, when I say I'm certified in compliance, don't know what that means, and that makes me sad, not for me, but for them, because compliance is just not just a bunch of regulations that are somewhere in the Federal Register, although it does do that. It's day to day. Let's keep my practice going. Let me sleep at night. Let me keep my staff and understand how important they are, and be able to provide this care to the patients who rely on chiropractic so heavily to make their lives better. And that's my whole life's work, has been that.
Okay, awesome. Well, I am going to stop the recording now, and then we had some more docs earlier. Now we just have a couple left, so we're going to do a Q&A. So here we go.